Thanks, John, and thank you, Catherine, for making me look bad in advance of the talk. That was a beautiful story. It's a compelling brand. I can see why you're traveling all around the world talking about realistic medicine. And now I get to talk about how we get doctors to fall in line. So I started, so John's correct, I've moved over to the dark side, but I did that when I became a health economist, although I'm not a real economist, just to be clear. But about 3 months ago, I also took a leadership role, the medical director of the Strategic Clinical Networks. And so I do think a lot about the things that Catherine was talking about. But actually, one of the reasons why I took that job was one of my close family members developed an unexpected and serious illness over the Christmas holidays. And I've spent the last 6 to 8 months on the other side of the hospital bed. And I've been trying to think, it's very simple when you're trying to ration resources, how you would do it until you're at the other side of the bed and you're thinking about how the physicians and how you would want them to think about resource stewardship in that context. It's also made me recognize that if we want to do this along with physicians, it's clearly we have a responsibility to partnership. There has to be leadership at all levels, including at the physician levels. And I'm certainly not going to stand up here and be critical of healthcare providers around resource stewardship, because it's actually a very difficult thing to be in a position where you're advocating for the patient, but at the other hand, you are trying to be a steward of resources within the context of a publicly funded healthcare system. But I hope what we can do today at least is talk through some strategies to actually help physicians and healthcare providers be stewards of resources in their daily practice. We'll talk a little bit about education, and one of the things that I think what Catherine has demonstrated is that if you have the right brand, it will prime people and get people behind a movement, and will get them will be willing to do other things that they may not have been willing to do if they didn't believe in the brand or the culture change that was necessary. And there's clearly some culture change that's necessary to get this movement out. But I think if you're in the education, read the educational literature. Large group education like this, we ain't changing behavior today. Catherine has shown that you can get a brand out there and that can prime things, but small group education, maybe you can get a bit more, but if all we try to do is educate healthcare providers about the importance of being a steward of resources, we're not likely to get far. But I think there are some feasible structural tweaks that we can make to the system to enable resource stewardship to become part of people's everyday practice. So that was my reflections point. I also, whenever I think about this, this is an awkward tightrope that we walk when we're looking after patients. And we often think of it as the patient and provider against the system, when I think we need to turn that around, that the patient's actually working with the provider who's working with the system, and that it's a partnership. So we'll talk a little bit about some strategies that we might be able to put in place, and we're already starting to think about this in partnership with the IHE. So just to give this some context, and this is a slightly older slide, and in fact, in some ways the systems are moving away from glucometer testing now to transcutaneous sensing of blood glucose levels, and that's the current challenge that Alberta Health is facing around funding decisions on that. But this would be a very typical story, a lady with, actually I would have said an older lady, but as I age I would say just an adult with diabetes, high blood pressure, on appropriate treatments to lower the blood sugar, appropriate treatments for high blood pressure and to protect the kidneys, comes into the office and the blood sugars on average are a bit high. And actually this could be a physician that she's coming to see, or could well be a nurse clinician in the same boat. And you send her out suggesting that she monitor her blood sugars and have her back in a couple of months. And one of the struggles that physicians have is we learn about Hippocrates very early on, who told physicians that I will apply for the benefit of the sick all measures which are required. And that's sort of the elephant in the room often when we talk about resource stewardship with physicians and healthcare providers. How do we manage that awkward tension? We also, as Catherine, patients are not sheep, physicians will tell you, and they're right. They're all different. They don't necessarily all fit into a clinical practice guideline, and they have nuances to them that means you need to talk with them. When physicians say this, I don't think they're necessarily thinking about the shared decision making, but they're thinking about the different characteristics a patient has. And you'll also know that, I'm sure people at the ministry will certainly know this, that physicians are fiercely independent and they don't like to be told what to do, and they're largely independent practitioners in the province. But we know that healthcare expenditures went from 100 billion to 200 billion over the course of 10 years. And we know from these league tables that although we spend a lot of money, actually our performance is in the bottom two in many categories in a survey that was ministered across many different countries. You've all seen this before, the Commonwealth survey. So why? There's many reasons. We could spend the whole afternoon talking about that, but of relevance to today in terms of healthcare providers as stewards of resources, one of the things is I don't think we have good alignment of what priorities are between healthcare providers and groups like Alberta Health Services or the healthcare funders. And oftentimes healthcare providers actually don't even necessarily know what the health system priorities are in their area. I think another big one that we can start to tackle is that performance measurement and continuing to try to improve, continuous quality improvement is not part of the culture that's embedded into physician care. So if we go back to that case example of should we send that person home to check her blood sugars for a few months before we see her back and decide what to do? Well, and again, this is an older systematic review that the Canadian Agency for Drugs and Technologies in Health led. It was a health technology assessment as well, simply looking at the cost effectiveness of self-monitoring or blood glucose testing in people with diabetes who were not on insulin. There was the usual 7 pretty good quality randomized trials. They measured A1C, that measure of average blood glucose control. And on average, the blood glucose control went down by about 0.25%. And we think that a clinically relevant change would be 0.5 to 1%. We also think now it really depends on the agent that you use. And when you translate that, yes, that could lead to changes in, depending on the agent you used, to slightly lower risk of heart attack, slightly lower risk of strokes, but probably the numbers needed to treat are in the 200 to 500 range, so very small improvements in health, and it's quite costly. So the baseline cost per quality adjusted life year gain for people not on insulin was in excess of 100,000, and provincial governments across the country turned this into funding rules around how much they would fund for diabetes testing supplies. But yet the physician actually is the one that's recommending to the patient to do this testing, and then they're going out and trying to figure out how to pay for it. Most systems, Alberta is actually in a bit of flux. They used to fund $600 per year for people on insulin. It's actually a little unclear to me what the program is. I think it's been grandfathered for people that were previously on it. But that's the reason, as I mentioned, this has turned a bit into an issue around whether to fund these transcutaneous sensors. But again, the physician might look at this in the context of resource scarcity and say, well, actually patients don't like to poke their fingers, and actually she'll bring that list back in, you'll glance at it, and you'll look at the A1C level, and you'll respond based on that, the blood test. So maybe we should not be prescribing self-monitoring in stable patients, except maybe when you're making changes in therapy or for people who are prone to low blood sugars. One of the tensions that exists, though, is that actually the guidelines very clearly 5 years ago from the Canadian Diabetes Association stated you should be doing this. Now they've tempered that and talk about in certain situations. But you have this tension where guidelines are telling doctors to do one thing, yet the funders are doing something else. So, and again, these are the types of things when I talk to residents about when you're thinking about balancing the patient in front of you with the patient in your waiting room. Because if you spend money on the first patient, money may not be available for that next patient or for somebody in your colleague's waiting room. And often when we actually go through these questions, much like the questions that these questions are meant to make the physicians think about whether that test they're thinking about ordering or that treatment are worthwhile, If you simply actually read the study carefully or look at the body of evidence, do we actually know that it improves health, or is it just improving a lab test? And do we know that it improves health in comparison to what we're already funding or what we're already doing? Or was it being compared against a placebo? So we're not actually certain if it leads to a lot of benefit. What are the resource implications of that treatment in comparison to what we might do? And is there a stepped therapy approach? So we'll try the trusted old medication that's less expensive. If they don't respond to that, we can escalate, and we can escalate again. And a lot of patients will not then end up at that more expensive therapy. But at the end of the day, sometimes we go up that therapeutic ladder, or we look at it and we still don't think it's cost effective. And that's going to be the uncomfortable truth, that we have to figure out how do we actually embed that into daily practice. That resources are limited, choices have to be made. Politicians may not like to say this, but we do ration. We don't fund everything in the healthcare system. Whether we call it realistic medicine, or that we simply can't afford something, or it doesn't offer value for money. We have an obligation to the patient, yes, but we also have an obligation to society. And if the goal of the healthcare system is to sort of maximize health within the budget that we have, then considering costs and how much things cost to purchase health is reasonable. But again, if we tell this to physicians, I don't expect that it's necessarily going to lead to changes in how they practice. At a system level, we've been advocating for a while, and actually now guideline organizations are finally starting to come on board in terms of taking cost into account when they make their recommendations. And perhaps that's going to align what the funders are recommending as well. And physicians often find inventive ways to get around formularies that maybe restrict use of tests or treatments. And because we think that those formularies they don't know the circumstances of my patient. But if we can get physicians to buy into that, actually there's a lot of your colleagues that sit on these committees, and they're actually doing you a favor. They're going through all of the evidence, and they're going through all the information on cost effectiveness, and they're trying to tailor an approach that works for the vast majority of patients. So it actually can help you when you're thinking about what to prescribe to that patient, because what's available to the patient is this. That's something that's affordable to them. Let's get them on that. Okay, but again, we haven't really gone through any strategies to actually get this into daily care. We've been talking with the Institute about developing some education, and Catherine has started to embed this into the medical schools, which I think is really critical. The question is, when do you actually embed that? Because when you're a medical student, you just want to figure out, how do I treat pneumonia, and how do I open up a coronary artery? They're not so keen on how much does this cost or does that cost. And so we're going to talk a bit about some system level changes that are feasible, and as well as some provincial and local initiatives aimed at practices where healthcare providers work. So again, we know that education can be effective, and it's probably important to prime the system. Large group education like this, the best we can hope for is, I definitely enjoyed Catherine's talk. The third time was the best, actually. I liked your slides even better today. But you start to actually feel that brand, and you may respond to other things. Small group education, generally, if people also have set some objectives for their learning, is a more effective way of getting physicians to change their practice. But it's difficult to do in practice, to get the difficult to reach physicians in. Physicians have no idea how much things cost. We know that much for sure. We actually don't necessarily have good evidence that telling them how much things cost changes their practice. Interestingly, Ontario, in the lead up to election, was talking about within EMRs forcing the price to be there when they prescribe medications. Interesting idea, not clear whether it'll work, but something that we could test. But education on its own, as I say, is likely to have a small impact. One of the things that we're talking about with the college, and the college is wanting to lead on this, is how do we ensure that physicians on an ongoing basis are providing safe and high quality care. We don't have a great system of accountability, either accountability actually or maintenance of ongoing assessment of competence. One of the things that we can do, and it is feasible if we can get physicians to lead on this, is actually to get different groups of physicians, so the kidney doctors, and I'll give you an example of how we're doing this in the province, but other groups of physicians to agree on what high quality, safe care looks like, and then to embed a measurement framework in place, and then to actually share that information back with physicians with the goal of supporting care, not necessarily using it in a punitive way, but physicians are quite competitive. Bone and Joint uses this within hip surgeries and knee surgeries, and the vast majority of physicians actually, when they see their information compared to their colleagues, want to improve. So what this looks like in kidney care is we got physicians together, we followed an established process to develop some indicators that all agreed were important, engaging physicians at the start, getting their buy-in, making sure that they believed the data source as well. There's lots of issues still around, do we have a target around each indicator, or is the improvement, we just try to encourage improvement. Getting physician buy-in is critical up front. And then this issue is this a carrot or a stick? Are we supporting physicians or are we enforcing it? So what these examples look like in kidney care, and the beauty of this is that you can embed costs into these indicators. So we know that home dialysis is at least as good for patients and it's less expensive. We have studies that tell us that starting early based on lab tests that show that your kidney function is bad doesn't improve patient outcomes, and it costs more. So those first two indicators have embedded high value care into the system, and physicians have agreed on them. The last one around this, we're trying to embed what Catherine talked about into an accountability framework for physicians around ensuring they've talked to patients about their wishes when they start dialysis. What about alternative payment models? So Catherine showed that variability still exists regardless of how you pay physicians. Alberta actually has developed academic relationship plans for specialists, and they've also developed some models of care aside from fee-for-service for primary care physicians, but still about 86% of physicians in Alberta are paid fee-for-service. What we know from our specialist alternate relationship plans, and it's actually hard to test these things out because we often have shared models of care, but when we look at patients who are referred with chronic diseases to see a specialist, if you're paid if you're paid by salary, you're about 12% less likely to have, or you'll have 12% fewer follow-up visits. Now, of course, we don't know what the right level is. We know that the quality of care actually provided is similar. And we know from other jurisdictions that paying fee-for-service encourages use of elective procedures. That's where it really has an impact on volume. What about blended capitation for primary care, which is a bugaboo in Alberta Health's or a challenge for them right now, but trying to encourage primary care providers to move away from fee-for-service. We know from the literature that fee-for-service, you will have a higher number of primary care and specialty care visits compared to salary, and patient experience is better in non-fee-for-service type payment models. So other things that you can do to embed this in regular care. So we're experimenting with pathways across the province, and I would say that pathways in acute care has been easier to move forward than pathways into primary care. But the nice thing about pathways is that you can embed the guidelines and you can embed medications that are funded by the formularies into pathways, and if you can encourage use of those, again, you still have to have those conversations with patients. But if you can embed cost-effective testing and treatment strategies into pathways, that's a way to sort of embed it into daily care. Order sets are a great way as well. If you want to encourage physicians to do things, make it easier for them. So if you've got, this is how we start patients on dialysis, you write it out for them with the least expensive dialyzer there, and all they have to do is sign their name to the bottom of it. They're very willing to do things that seem reasonable and have gotten their buy-in, particularly when it makes it easier for them. And then transferring tasks from physicians to nurses using protocolized care, again, embedding cost-effective treatment or target ranges for therapies or what tests need to be ordered into protocolized care, easier for doctors, better for the healthcare system. And there's going to be a huge role for Connect Care. Connect Care is a platform that, if we use it properly, can be used to enhance this kind of care. So back to Hippocrates, because he didn't just say that we have to do everything for the patient in front of us. Actually, he said, I'll apply for the benefit of the sick all measures that are required, avoiding overtreatment, and undertreatment, therapeutic nihilism. And I'll remember that I'm not treating a fever or a cancerous growth, but a sick human being whose illness often affects their economic status as well, as Catherine pointed out, and that my responsibility goes to those areas as well, not just their medical illnesses. And actually he said, which is quite far thinking, considering treatments probably didn't cost much back then, but I'll remember that I remain a member of society with special obligations to all my fellow human beings. And as Catherine stated, there's clearly a role for shared decision-making and personalized medicine, and there will always be an art to medicine, but I think high-value care will actually be relevant to the majority of patients. And yes, physicians are fiercely independent, but we should start to acknowledge that computers can actually diagnose as or more effectively as physicians can these days. And actually, I think where we're moving is that there truly is an art to medicine, and that communication and managing a roster of patients is going to become our most important task as we move forward. So I think physicians and healthcare providers, we are seeing a change. We will see a change over the next 10 years, and we really need to be considering some of these things I've mentioned. Does this treatment really impact health? Guidelines should consider costs. There's definitely a role for clinical pathways and order sets and nurse-led protocols that can embed value for money into daily routine care. And I do think that there's a way that we can align the priorities of healthcare providers and the healthcare system through using accountability frameworks and indicators of high-value care. So I will stop there.